Or yeah, so it looks like there's enhancement
What's
of
all
the
that?
yeah, it looks like it's along the superior oblique muscle.
What's
Abnormal
that
enhancement. Sorry, inferior rectus,
guy? What's that guy?
medial rectus,
What's that guy?
lateral rectus, superior rectus.
What is that guy? And what is that?
Yeah, so abnormal thickening and enhancement of the superior rectus muscle.
Yeah, you're too
I'm not
high
sure.
up here to be superior rectus. So what's all this?
Yeah, abnormal enhancement in the soft tissues anterior to the orbit.
Right. What if that's not cellulitis? What if it's not a preseptal cellulitis? Then what do you think about?
Like tumor invasion.
Like tumor. What if this is all squame?
So maybe a squamous cell carcinoma that's invaded into the superior rectus muscle.
What are the three big things you want to talk about every time you have a squamous cell carcinoma of the head and neck? You talk about the primary, where is it centered? Where is it? Where does it go? How big is it? And we look for...
Is there a perineural invasion?
We look for perineural tumor spread and we look for lymph nodes. If you have a tumor here, where's the perineural tumor spread that you look for?
Is it going to be V1 division
V1.
of trigeminal?
Where does V1 go?
Trying to think. So it's going to go along that path you're outlining there.
Along that path, and there's a cleft here between the greater and lesser wing of the sphenoid at the level where the optic nerve canal is going back.
Mm-hmm.
What is that? It's a fissure that's above the inferior orbital
superior
fissure.
Orbital fissure.
The supraorbital fissure, what goes through there?
Is it the ophthalmic vein?
Well, it's all the nerves to the eyeball. What are the nerves to the eyeball?
So cranial nerve 2, cranial nerve 3.
Well, 2 gets its own hole, right? He goes through the optic nerve canal. So 3, what comes after 3?
4.
4, good job.
And
And
6.
what is this nerve you think it is? Perineural tumor spread from the forehead?
So yeah, V1 of 5.
V1 of 5, and what comes after 5?
6.
6. So 3, 4, V1, and 6 all go through the supraorbital fissure. That's a cleft between the greater and lesser wing of the sphenoid up high. Good. Okay, next. See, Matthew.
Ready. Left-hand side of the screen, we have a CT of the temporal bone, coronal. And on the right, we have an MR. I'm not sure what sequence. Looks like post-contrast.
Yep.
So there is a mass kind of centered in it. I think it is in the clinoid. No.
Well, the clinoid's at the midline, right?
Mm-hmm. It's centered skull base mass with some scalloping.
What's this guy?
That is the that's the eagle beak.
Where is this centered?
Superior to that.
Well, it's lateral and superior to that. What is that? That's just like superior and lateral to the bird in profile.
Is it like the jugular bulb?
Jugular foramen. We have a mass centered at the jugular foramen.
Yes.
Osseous changes are?
It is lytic.
Permeative destructive. It's destroying the bone.
And
is it destroying the bone mostly laterally or mostly medially?
Mostly laterally.
Mostly laterally. And on the
and
MR?
Salt and pepper. So I'm already thinking of paraganglioma.
There's a paraganglioma centered at the jugular foramen. So
yes, so jugulary, it's the jugulary one.
The jugulary one, jugular foramen paraganglioma. And what is their usual vector of spread?
Laterally and
superior and laterally up towards the middle ear cavity. All right, good. Okay, Grace? See if you can figure out how to unmute yourself.
I deserve that.
Victory!
Okay. Oh, woohoo! Okay, all right, so we have an axial and coronal MRI, and this is the contrast enhanced since the nose. And we can see, okay, now I need to figure out where the abnormality is, which is not coming to me at this moment.
I'll look for asymmetry. What do you think of this side compared to this side?
Oh, the right side looks fuller compared to the left side.
Right side
Oh.
what?
The right side of the cavernous sinus.
Cavernous sinus. We have mass effect from the cavernous sinus. Okay, what lives in the cavernous sinus?
Well, we have a bunch of nerves and a bunch of blood. So I know 3, 4, V1, and then
So
6.
from where the pit is,
Yes.
we think about the cavernous sinus, those valveless venous sinusoids that are on both sides, and they connect under the pituitary gland. So you have the little oculomotor cistern where 3 is, and then you have 4, V1, and V2 going down the wall. The most medial object in the cavernous sinus is
6.
well, the most medial object, not nerve.
Oh, the carotid artery.
Carotid. The nerve that's right next to the carotid is
6.
6. Okay, good. So we've got dural sleeves here. We've got veins. We've got nerves that are all going through, and we've got the carotid. So any pathology that can happen to that anatomy can happen here. So we have nerves here. Therefore, what kind of tumors can you get there?
Therefore, you can get like nerve sheath tumors.
Nerve sheath tumors like schwannomas. We have the carotid there. So what can happen there?
Like a paraganglioma is possible. No, sorry.
Well, if the blood vessel gets bigger,
Oh, you can have like an aneurysm.
aneurysm. We've got veins here, so you can have thrombosis, you can have infection there, and you have all these dural sleeves. So
Yeah.
what's an extraaxial dural base mass?
Like a meningioma.
Meningioma. Or we can have just Mets kind of at that location. That's your differential. If I tell you this hurts,
Then I think about like inflammatory pseudotumor, like IgG4 kind of disease.
well, IgG4 doesn't always hurt, but what is often called Toulouse-Hunt, IOID, idiopathic orbital inflammatory disease, or Toulouse-Hunt, if you like to name shit after dead people, can happen there in the cavernous sinus. That's right. So that's your differential for a lesion there centered in the cavernous sinus, right?
Okay.
Okay, good. Next case, April.
Okay, so we have axial and coronal T1 fat sat post contrast images. We have so we basically have expanded space anterior to the bilateral temporal horns that follow CSF on this sequence without enhancement. I'm wondering if this is an arachnoid cyst. I'm trying to find it on the coronal. Maybe I'm.
Is that a good place for an arachnoid cyst?
Yes.
That's the best place for an arachnoid cyst. But what is on the other side?
On the other side, I think also an arachnoid cyst.
Do you often see them bilaterally?
Yes. 30% of the time. 70% of the time.
In fact, probably less than that. It's pretty rare to see bilateral. Would you
Okay.
be interested in a clinical history, miss?
Yes, I would definitely be.
You would?
Yes, please.
His left eyeball is not moving correctly.
So now I'm looking at the axial with new enthusiasm, and I see a. So I think I see a kind of tubular enhancing structure that is around, yeah, right there, kind of the medial temporal horn space. And I think I see it as well on the coronal, just looking at me right there. Yes. So enhancing and linear. I'm wondering if this is, I've never seen the nerve enhance.
Did the cisternal segment of cranial nerves enhance?
They shouldn't, but if they do, it's bad. The other thing is, could it be a vessel? All of our, other high flow vessels are dark, but this is not a sequence we usually see like a flow void on.
If that is a nerve, what nerve would that be?
6? No. Yes?
Where
Thought?
does 6 come out?
Like behind and then travels around. No.
So
Makes
if you look at where the fourth ventricle is, there are those two little bumps right there.
Yeah, the colliculi or something.
Those are the facial colliculi. The motor nucleus under that is 6. 6 comes anteriorly, comes out the pontomedullary junction, goes anteriorly through the abducens canal, or Dorello's canal, if you like to name shit after dead people. Goes under this ligament, the petroclinoid ligament, or Gruber's ligament, that goes forward to the cavernous sinus. So that comes out of the front at the pontomedullary junction. Where does 4 come out?
4 comes out behind. I knew it was an even number.
4 comes out of the back. So if you look at the front of the mesencephalon, where it looks like a heart shape, that's where 3 comes out. And near that level, there's a little triangle in the back. That's where 4 is. The motor nucleus of 4 is back here. And 4 does a stupid thing. It crosses over to the other side, so the 2 cross each other, and it goes all the way over to the side. So if you think about those branches that come off from the basilar tip, 3 and 4 are both going in between that PCA and SCA. So 4 is the longest cisternal segment, and it comes out. And just at the lateral side of the mesencephalon, there's a transition zone between the central and peripheral myelinization that we talk about. Osler, Zoser zone, something if you want to name stuff after dead people. And a lot of people think that a certain type of tumor often occurs at that transition between the central and peripheral myelinization, which is right there. What kind of tumors happen there?
So would they be peripheral? So I'm trying to decide whether or not you're trying to get me to say like the type of nerve sheath tumors or the nerve tumors that happen at the eye, like a central, or if you're trying to say that they happen like peripheral ones, like more of a
name a nerve sheath tumor.
Like neurofibroma, schwannoma.
Schwannoma. So schwannoma is what you're usually talking about. So that's where schwannomas of the fourth nerve like to occur, right there. And that's where we think about the transition from central to peripheral myelinization. So that is a fourth nerve schwannoma, and that's the classic position where we always see those guys.
Okay.
So clinical history totally changes how you read that out, right?
Yes.
Right. Okay. Matt,
Thank you.
See, do we start with Matthew or start with Tyler?
Christian just joined us.
Oh, Christian?
Hey, sorry for being late. Oh, this is my case. Yes.
Your case, go.
So we're looking at a axial CT bone kernel of the left temporal bone, and T1 postcon MR of the same region, I think. So the ossicles, they look like enlarged on the CT. They look a bit abnormal.
I'll give you that.
The ink is not sure what to make out of that.
I'll give you that. Ossicles are good.
Okay. Then there's some osseous expansion of the ridge of the apex, I guess, anterior to the there. So that's expansile. It has such maybe a little bit eroded, but it looks benign and very circumscribed. And it has this kind of
weird
ground
kind of spiculated laminated bone that's being laid down.
Yeah, could it be another case of the fibrous dysplasia?
It's not really ground glass, and
Okay.
it's at a certain location. What comes out goes through the IAC and goes through this little canal right here to this area.
It's the facial nerve. That's the
Facial.
genu of the. Yeah. So
There's a little branch off the facial nerve that goes forward. That's the greater superficial petrosal. And the tympanic segment goes just under the lateral semicircular canal. That's the tympanic segment that goes back. So we have a lesion that's kind of centered at the geniculate ganglia. It's expansile, it's avidly enhancing, and you have weird laminated spiculated bone that's being laid down at that location.
Yeah.
So this could be a marrow replacing process, Mets, myeloma, lymphoma, leukemia, plasmacytoma, E2 sarcoid, any of those things. But this is a classic appearance for a facial nerve venous vascular malformation, what used to be called a facial nerve hemangioma, with that spiculated bone that's being laid down. So you see where the labyrinthine segment is going over to the geniculate ganglion. That's where the greater superficial petrosal nerve comes off. He goes immediately lateral to the horizontal segment of the carotid. There's always a break in the bone of the carotid where the sympathetic fibers from the carotid join these parasympathetic fibers from 7, and together they form the long, thin, curvilinear pterygoid or Vidian canal going forward. So this is a classic case of a facial nerve venous vascular malformation or facial nerve hemangioma. Does that make sense?
Yeah, it does.
Okay, good. Okay, Tyler?
All right. So axial CT through the skull base, or sorry, coronal CT. And it looks like we have scalping of the hypoglossal canal on the right, kind of scalping and expansion rather. So I'm thinking hypoglossal like schwannoma or
Perfect.
some sort of nerve sheath tumor.
So what goes over the head of the bird?
Is it the foraminal valley that we're seeing kind of right there?
Well, no, this is the bird in profile. So what is that area just lateral to the bird we just talked about?
Yeah. Terrible short-term memory, I suppose.
You may not know this, but it's always easier to be the one asking the questions than the one answering the question. So the jugular foramen goes over the head of the bird. So 9, 10, and 11 go over the head of the bird. And what comes under the beak of the bird?
12.
12. Right. And as you said, these are classic, expansion and kind of benign looking bowing of the bone at that location for this guy who had a big hypoglossal schwannoma at that location. That's right. So that's a great appearance for hypoglossal schwannoma. So how the bones are changed, and around the skull base, we know that getting a bone algorithm CT and a contrasted MR is often very helpful because we can sometimes tell exactly what the differential is in that case. Good. So that's a great example of a hypoglossal schwannoma. So you have to think about the anatomy, what normally lives in that anatomy, and then what pathology happens to that anatomy, and match that list to a space-specific differential, in this case, how the bones are being affected. See, Dr. Weintraub, I think you're on now. Are you with us?
Yeah, hi, Dr. Wiggins. Sorry, I was having some technical issues.
That's okay. You take this one.
Can I ask you a quick question about that last?
You can ask me anything.
Oh, don't promise too much. What is the name, what is the osseous structure of the bird? Like, what is it actually called? You can't call it like a bird speak in
we think about that as the jugular tubercle, that little thing that separates the pars nervosa and the pars vascularis we talked about the other day.
Yes, jugular tubercle. Okay, thank you.
No problem. Okay, Dr. Weintraub?
Okay. So we have an axial and coronal CTs through the orbits. There's asymmetric enlargement of the left lateral rectus muscle. I'm thinking of Graves' orbitopathy.
Is that usually the one that gets big first?
I am slow. No, it's not. In Graves, actually, it's I am slow. It's actually one of the last. So probably then more likely a pseudotumor.
What would you expect clinically then?
I would expect a lateral rectus palsy. So if they ask the patient to turn his head to the left, he can't turn his left eye.
Eyeballs move, okay.
Mhm.
Any other questions? If the
No.
eyeball's trying to escape the skull, you should have two big questions. What are they?
Oh, is there exophthalmos? Or proptosis?
That's the eyeball trying to escape the skull. You should have two big questions clinically. When the eyeball's trying to escape the skull, what is that? I'm not interested in big doctor words. What are the two big questions you should have?
Is the patient having visual loss?
Did the proptosis happen quickly or slowly, and does it hurt?
Oh, okay.
Does pseudotumor hurt?
Yes.
Pseudotumor hurts. This hurts. So it could be a mass in a muscle, could be a mass just next to a muscle, but that's what we see with orbital pseudotumor. So it's not the right order for Graves' ophthalmopathy. What if this eyeball was pulled back into the head and there was a mass here that looked kind of like it was pulling everything around it and scarring it down?
It could be pseudotumor, could be a retinoblastoma, or not.
If the eyeball's getting pulled back, everything else is bigger. It's a mass, it's a tumor, it expands, it pushes things away. What if the eyeball's pulled back and it looks like everything's scarred down behind the eyeball? That's classic for serous breast carcinoma metastatic
okay.
disease. So
Okay.
METs can happen back there.
Mhm.
Now we can have METs, IgG4, lymphoma, there are all these other things, but pseudotumor hurts. And anytime an eyeball is trying to escape the skull, you have two big questions. Did it happen quickly or slowly? And does it hurt? You got that?
Got it.
Okay, good. So
With
Matthew?
with the cirrhotic breast metastasis, is that painful?
I think it can be, but the whole deal is that the eyeball goes back in. Almost everything makes the eyeball go out. So serous breast carcinoma, metastatic disease, serous, it's going down and pull the eyeball back in.
Is there anything else that causes
make
that?
sense?
Or is that like a pathognomonic? Yeah. Is there anything on
Oh,
the serous breast cancer?
what did we say?
Can you hear me, guys?
I can hear you,
I can
April.
hear April. I don't know if Dr. Wiggins can hear you.
And my audio is screwed up.
Seems like I don't think he can hear any of us, maybe.
That-
Can you hear us now?
Oh, there you are. What were you asking, April? What about serous?
I was asking, is that pathognomonic if we see a retracted
Yeah,
eyeball?
pretty much
and
is. That's
mass?
kind of an Aunt Minnie. If you see one eyeball that's pulled back in and there's a scarred mass kind of behind it that looks like it's pulling everything in, that's a great appearance for serous breast carcinoma. That's kind of one of those Aunt Minnies.
All right.
Okay, Matthew?
So this is me. We have MR post contrast at the axials, at the posterior cranial fossa, and then the midbrain. And there is nodular lumpy enhancement kind of throughout along the pia. And this could be sarcoid, it could be TB, could be metastasis, but I'm favoring sarcoid.
If it is Mets, what kind of Mets is that?
I think breast cancer.
Well, where are the Mets? It could be a bunch of different things,
Oh.
but what's the location? Is it
Peel.
dural?
This is peel, right?
Peel, yeah, right, like it's along the nerve. Yeah, granulomatous processes love the basal cisterns. So when you think of that 5 or 6 pointed star where the circle of Willis lives, if anytime you see it, what looks like a whole bunch of nodular enhancing dots around there, think about granulomatous processes like sarcoid or TB. That's right, good job. Let's see, April?
Okay, what is this structure? So I think this is the superior orbital fissure. No?
Well, at the level of the inferior orbital fissure.
Oh, we are at the level of the inferior orbital fissure. So
What is the superior orbital fissure at the level of?
the superior orbital canal.
When you see where the optic nerve goes through the optic nerve canal, where the eyeball is, the supraorbital fissure is at that level.
Okay.
There's a cleft between the greater and lesser wing of the sphenoid. So when you see where cranial nerve 2 goes through its own hole, the optic nerve canal, the supraorbital fissure is at that level. So we're well below that level. We're at the level of the horizontal segments of the carotids here.
Gotcha. Okay, so then the things that I'm thinking are that go like forward in the brain are rotundum and Vidian canal. So I'm wondering whether or not this is rotundum.
Rotundum. This is the rotundum canal. That's right. So you have this little short canal that goes forward towards the infraorbital fissure at that level. So what goes through rotundum?
V2.
V2. Good job. Okay. See, next, Grace.
All right, so we have an axial, looks like T2, and axial looks like T1. weighted MRIs, and we can see that there is a cystic and solid lesion at the cerebellar pontine angle, and with multiple fin septations. It looks like it's extending into the IAC, and so I think differential considerations would include like a cystic schwannoma. Another thing to consider would be like
Well, this is like a
meningioma.
mass with cysts between the mass and the brain.
So I think more like a neuro, like a schwannoma, like because maybe they can have like intratumoral cysts.
Yeah, so that's like in the tumor, but these are cysts like between the tumor and the brain. So statistically, is vestibular schwannoma a common thing to happen at the CP angle?
No. Yes.
Yeah, that is the most common thing. Is it
Right.
more common to have an atypical presentation of a common entity or to have an atypical entity?
Atypical presentation of a common entity. So
Common entity. This is a vestibular schwannoma that had kind of like arachnoid cyst between the tumor and the brain. Statistically, what would you expect this guy to show up with clinical wise?
sensorineural hearing loss.
Sensorineural hearing loss. If a guy shows up with sensorineural hearing loss and there's a mass at the CP angle, it's almost always a
Vestibular schwannoma.
vestibular schwannoma. Almost always, like 90% of the time, it's going to be a vestibular schwannoma if there's a mass at the CP angle if the patient clinically has sensorineural hearing loss. And it's more common to have an atypical presentation of a common entity than it is to have an atypical or uncommon entity.
Okay.
Good. Okay, who's next?
Is it me again?
Christian?
I think it's me.
Oh, sorry.
Oh, I think
It doesn't
Or
matter.
it doesn't matter to me. Sorry.
Everybody goes in the next rotation.
I just go next. So looks like we're looking at coronal and axial CTs, contrast enhanced through the vocal cords, and in the right vocal cords there is some dense material, possibly post-procedural. I know that they can do like injection of I'm not sure exactly what they inject, but material to help give bulk to the like a paralyzed vocal cord after surgery or vocal cord paralysis.
Sometimes I just shove a Teflon pledget in there like a little brick, but there's something called radiase that they actually inject. So you would inject radiase for what clinical reason?
Vocal cord paralysis.
Vocal cord paralysis. So where does that nerve go if you think they have vocal cord paralysis? Anytime there's an isolated cranial nerve deficit, you want to think about imaging from the origin nucleus all the way out through the end organ. So where are you going to image to evaluate the central cranial nuclei and the entire course of this nerve?
So it's cranial nerve 10. Central nuclei, I can't remember exactly where it comes, but it goes all
Well,
the
the
way down
middle
to the AP
nuclei are
window.
where? If you think about the mesencephalon, the big belly of the pons, and then the medulla down below,
Mhm.
if you kind of draw a line across that, which nuclei are in the middle where the pons is?
Is it 9, 10, and 11?
The middle guys, 5 through 8, we think about being in the middle of the pons. So we can think about 1 through 4 kind of being in the mesencephalon above, 5 through 8 being in the pons, and 9 through 12 being below the pons in the
Medulla.
medulla. So we're going to look at the medulla for 9 through 12, and then so it comes out. Where does 10 come out to the skull base?
Is it the foramen magnum?
Nope. There's only one thing that goes through foramen magnum.
12. Or maybe
No,
it's, I
12
can't
goes
remember.
out the hypoglossal.
So then it's, I can't
What's
remember.
one
I
less
want to
than
say it's
12?
11.
11. 11 is special. It's an accessory one. 11 is the only one that goes up through foramen magnum, makes a U-turn, and then goes out the what?
Hypoglossal canal.
No, 12 goes through the hypoglossal. What goes
Oh,
over
sorry.
the head of the bird?
So through the jugular foramen.
Jugular foramen. So what goes through the jugular foramen? What nerves?
9, 10, and 11.
9, 10, 11. Good. So we're going to start at the medulla. We're going to look at the jugular foramen, and then it goes down the neck through what space?
Carotid space.
Carotid sheath or space. And so where does it go down low to? What level are you going to look at down low?
The AP window, the aortic arch, just below the aortic arch.
So under the brachiocephalic on the right and the aorta on the left, and then it comes back up where?
Comes back up and innervates adjacent to the thyroid, so the vocal cords.
Where does it come back up? What location? It goes
I don't
down
know.
the carotid sheath or space, and then it comes back up the what?
I'm not sure.
The TE groove, the space in between the trachea and the esophagus. So anytime you have a cord paralysis, you need to image all the way along that course to evaluate that patient. Okay, Tyler, let's see. I'm just going to go back in the order we have you on the list. So Matthew.
You sure you don't want Christian or Michael?
Yeah,
I'll
I
do
think
Michael.
I'm the next.
Okay, Christian.
Maybe Matthew can take that.
Too late. Sucker.
So there's a mass in the sphenoid bone on the left that has a soft tissue component to it. It extends into the orbit, the middle cranial fossa, and also laterally into the superficial tissues. Yeah, I'm thinking about like something aggressive. Looks aggressive, like a mat. Maybe
in the MSK world, do you think about anything when you have this sunburst appearance to the bone?
a radiation-induced osteosarc.
Yeah, telangiectatic osteosarc, some weird, crazy thing like that, right? Would I try to trick you and show you a head and neck case that looks like that, but it's really something else?
Probably.
Oh my God, yes. What do you think about the soft tissue component of this thing?
It looks less aggressive, looks smooth.
It looks less aggressive. It's very important in the head and neck world when we think about the skull base and the extracranial head and neck. We not only talk about the pathology, but we talk about the stuff around it. Is anybody angry about this thing, or does nobody seem to care? What do you think about the soft tissues around the soft tissue component of this thing?
Yeah, they look clean. The intraorbital fat looks clean. Brain
Yeah.
looks okay.
Good dark
Just mass
fat.
effects.
Nobody seems to care, right?
So it is then probably more like a long or slow growing mass, like something benign.
So we think about, is this something intrinsic to the bone or extrinsic to the bone that's invading into it? Those are difficult for skull base. If we just have a marrow replacing process, we think about that big differential. Mets, myeloma, lymphoma, leukemia, plasmacytoma, e.g. sarcoid, all of those things. What if we ignored all of this and we just looked at that?
Oh, is that a transosseous meningioma?
Transosseous or intraosseous. If you just had this, you would look like a meningioma. It looks like a meninge that's there. So we like to see a dural extraaxial based mass with dural tails, but we can have meningiomas that are more globular and they can be intraosseous. This is an intraosseous meningioma. Is this a common location for an intraosseous meningioma?
I've seen a few high up in the calvarium. I would say no.
What's the opposite of no?
It is very common.
Yes, this is the
Very-
best place for an intraosseous meningioma. Good.
Okay.
So that's an intraosseous meningioma. The bones look very aggressive, but the soft tissues look very boring, and nobody seems to care about this thing. The guys right next to it don't seem to care. Okay, Michael?
Could I just ask a question on that case?
Yep.
So this sunburst-like appearance is the intraosseous component of the meningioma,
Right.
but then this area you were showing on the, I guess this hyperdense area surrounding it, is that soft tissue component?
That's the soft tissue component. So there's an osseous component that looks very aggressive, and the soft tissue component looks very benign.
Okay, so that's not reactive tissue. That's actually part of the tumor.
That's the meningioma.
Got it. Okay.
Okay. Next.
What can I ask you? What about a perihemangiosarcoma? Paralysis. I don't know if that's
Yeah,
the
we
real
have
thing.
all these weird fibro things and Pericytoma.
Yeah.
There are all these other variants of that. Those are kind of weird variants that we very rarely see. But
Okay.
this is a great location for intraosseous meningioma. That's where we normally see them.
Okay. Would we expect the imaging findings to be different if it was that, I think it's called a something.
The soft tissue component of those is more aggressive and invasive.
Okay. Okay. That's
And,
useful.
and
Thank
if
you.
it's metastatic disease, the surrounding soft tissue is going to be more aggressive and invasive.
Okay. Thank you.
Michael?
Okay. So on the left orbit, let's see. So the image on the top left is a non-contrast T2, I think.
Let's say those are both T1 post.
T1. Oh, okay. So there's lots of enhanced retro bulbar enhancement, extraconal retrobulbar enhancement in the left orbit with proptosis. There's enhancement and enlargement of the left extraocular muscles, and then the angio is showing it looks like a internal carotid run. I think this is a lateral view.
Lateral ICA injection. What do you think about this eyeball?
The eyeball looks eyeball itself looks okay, but I think it's the retro bulbar soft tissues are abnormal. I mean, there's a lot, or there's
Is the
lots
eyeball
of,
in the right place?
no, there's proptosis, exophthalmos. So there's something pushing it out. There's lots of edema, lots of soft tissue, both preseptal and postseptal.
Do you have any questions you want to ask clinically?
Is it painful? Is it acute?
This happened quickly and it hurts.
Mm-hmm.
So what's this?
That's the internal carotid artery.
What's this?
Oh, that's either the ophthalmic artery or superior ophthalmic vein. I think the ophthalmic artery.
It's like a big vein that's up high in the eyeball.
Okay, so if this is a superior ophthalmic vein that's dilated and that we see filling with the ICA run, then this makes me think of cavernous carotid cavernous fistula.
There's a connection between the artery and the vein. This guy had trauma and he has an unusual connection there. So when you inject the carotid, you're filling all the veins. So that's a CC fistula.
Mm-hmm.
So sometimes we talk about indirect or direct, and it, to happen fast or slow, is it post-traumatic or things like that. Right. Good. Okay.
So all of this retrobulbar enhancement, I mean, is it true that the muscles, the extraocular muscles all seem dilated and enhancing?
Yeah, everything gets engorged and kind of backs up.
I see. Okay.
There you go. See that? Can you see all the cavernous sinus stuff now?
Yeah.
So this side is normal, but there are all these weird flow voids.
Yeah.
So that's a good case for a CC fistula. Good.
Okay, cool.
Okay. Who's next?
I am.
Okay.
All right, we have 2 MRIs of the kind of medulla area or like foramen magna. One is T1 pre-contrast. The other is T1 post-contrast, I believe.
Let's say it's a proton density in a T2.
That would make more sense. All right, the finding is in the right internal carotid artery. There is a crescentic T1 or PD hyperintense or T2 hyperintense lesion surrounding the flow void, compatible with dissection.
What if it just happened?
Could still just be a right ICA dissection.
What if it's bright on T1?
Then it's definitely then it's definitely a dissection.
But if it's bright on T1, could it have just happened?
Yes, because the whole blood pattern MR signal only applies to intracranial blood.
Blood in isolation in the brain. As soon as it
Yeah.
mixes with CSF or it's outside the brain, those rules don't count.
Yes.
So even if it's bright on T1, we look for that great crescent around the outside.
Yes,
Good job.
and classically we get T1 fat set images to look for this.
We do T1 fat set, even if it just happened. If it's blood in isolation in the brain, it shouldn't be bright till it's 3 days old. But if it's somewhere else, those rules don't apply. If it's in the femur, it's in the neck, or it's somewhere else, that's very different.
And when you say bright, you mean T1 bright, or you just mean
T1 bright. So if it's T1 bright, blood in isolation in the brain, it should be at least how many days old?
You said 3 days old?
I did. How many do you think it is?
3.
Good job. Next.
Is it me? I don't know.
I don't know. Go ahead. You started talking.
Okay, so we have an axial CT of the temporal bone, and there are multiple expanded like sorry, I know I'm saying renal. Okay, the calvaria is expanded, and there's ground glass opacity within the calvarium. So the thing that I'm thinking about is fibrous dysplasia.
So how do we classically describe fibrous dysplasia?
We say, ground glass matrix within ground glass and expanded bone.
Expansion and ground glass.
Yeah, ground glass, yeah.
So what if it's increased density instead of kind of ground glass? And fibrous dysplasia has relative preservation of the otic capsule, the dense bone that's around the cochlea and the vestibule. What if you have something that's going right up through the otic capsule, and there's this appearance of the bone that's kind of expansile, but looks kind of like some pulled thing?
Will we start thinking about like Paget's?
Paget's, osteodystrophia deformans, or Paget's, if you like to name stuff after dead people. This is the cotton wool appearance of Paget's. Sometimes it looks a little bit like fibrous dysplasia, but we talk about these waves of osteoblastic and osteoclastic activity with the cotton wool appearance of osteodystrophia deformans, or Paget's. And Paget's does not care about the otic capsule. So you see how it goes right up through the otic capsule at that level and is touching the bone. So this is actually osteodystrophia deformans, or Paget's, instead of fibrous dysplasia. That's right, good. Let's see, who's next? April?
Yes. Okay, so we have a 2 axial sequences, T2 and a T1 fat sat post contrast.
Yep.
We see enlargement with increased CSF space around the optic nerve on the left without abnormal, definite abnormal enhancement. So I'm wondering, I also think we have maybe some flattening of the retina on that side.
You think there's a little bit of flattening?
I think there's like inversion,
Yeah,
basically.
it's like pushing out into the eyeball.
Yeah. So I think that this is intracranial hypertension.
It's a great case for intracranial hypertension, or intracranial pseudotumor, what some people call that. Yeah, so we have prominent CSF along the optic nerves. We have redundancy of the nerves. We have flattening or inversion. Sometimes on the flare or the post, we have a little dot of weird signal or enhancement right where the optic nerve hits the eyeball. Partial empty cella. Where the petrous apex is, we sometimes get petrous apex cephaloceles because the trigeminal cistern or Meckel's cave kind of erodes down into it. And we often have extra arachnoid granulations along the middle cranial fossa. So depending on your patient population where you end up, if you have a lot of good big Americans, you might see a lot of intracranial hypertension patients. Good. Next.
I think we're at the beginning again, guys.
Comes back to me. So oral cavity, I would think 1 and 2.
Where's 1 and 2?
Number 2, yeah.
So where is level 1?
Oh, sorry, level 1. So 1A is kind of medial, below the chin. 1B, go a little bit lateral, adjacent to the mandible, but anterior to the submandibular glands.
Yeah, so if you think about where the submandibular glands are, if you draw a line through the coronal plane behind them, and then you think about where the carotid and the jug are, and you draw a line through the back of the carotid, and then you think about where the sternocleidomastoid is on both sides, and you draw a line through the posterior edge of the SCM. So 1 is going to be in front of the submandibular gland. 2 is behind that. Behind the jug, if it's more than a fat plane behind that, we think about that as level 5, certainly below the SCM. We think about 5 being posterior to that. So we sometimes divide up 2 into 2A and 2B if it's behind the jug, the internal jugular vein right there. So you take the submandibular gland, the jug, and the SCM to try to separate those levels. And oral cavity, where the tongue is in front, we think about level 1A between the anterior bellies of the digastric and 1B out laterally in front of the submandibular gland at that level. Good. Okay, next.
I think it's Christian, then Michael, then me.
Yeah.
Christian?
Soft tissue mass in the tympanum, in the epitympanum and mesotympanum, I think.
Yep.
It's between the capsa and the ossicles.
So it's in the middle ear cavity.
Right.
There's a mass in the middle ear cavity.
All right. So I'm thinking, could it be maybe a paraganglioma? Wouldn't be classic location.
So what is a classic location?
When it's sitting at the cochlea promontorium.
So the cochlear promontory is here. So if there's a little mass sitting on the cochlear promontory and you've got a red mass behind an intact TM, that's good for a clomis tympanicum.
Yeah.
And the TM goes from the scutum or shield medially and inferiorly down to the tympanic annulus, the little bump that's below it. That's where a glomus tympanicum tumor is. It sits on the cochlear promontory. If you have a jugular paraganglioma, it has a supralateral vector of spread up into the bottom of the middle ear cavity. So that'll look a lot like a glomus tympanicum at that level. What if you had a lot of osseous destruction? It looks like you still see the ice cream cone in this case. It's there and it's in the right place.
Yeah.
What if you had a soft tissue mass that was destroying the ossicles if it was eating the ice cream cone? Then what would you think about?
Also, a paraganglioma can do that, I would think.
Usually it's pushing stuff out of the way. We see permeative destructive changes with a jugular paraganglioma. What if you have a kid? Anytime you have a non-gravity dependent homogeneous soft tissue mass in the middle ear cavity with some type of osseous destruction, it's almost always a
Cholesteatoma.
cholesteatoma. So it's almost always a cholesteatoma if we see that. Here we have a soft tissue mass that's pushing the ossicles out laterally instead of destroying them. And there's a nerve that goes just like that under the lateral semicircular canal. And it comes anteriorly from here above the horizontal crest, and then it goes back posteriorly here. What is that nerve?
So it's the facial nerve.
The facial nerve. What kind of pathology happens to the facial nerve that we often talk about around its course?
Tumors.
Tumors. What kind of tumors happen to nerves?
Schwannoma and
Bam, schwannoma. So facial nerve schwannoma is something that we include here. We're going to look very carefully to see if there's any osseous destruction, because usually this is going to be a cholesteatoma. If you have a homogeneous soft tissue mass that's not gravity dependent with some type of osseous destruction, the ossicles, the aortic capsule, something that's centered in the middle ear cavity, it's almost always a
cholesteatoma.
cholesteatoma. In this case, if we don't have any osseous destruction, we might think about a facial nerve tumor like a schwannoma and that. Steve got vaccinated. Sweet. Who's Steve? So this is a facial nerve schwannoma. Okay, next case. Who's next?
Okay, that's me. So there's a large enhancing lesion centered in the.
This is a coronal and axial post-contrasted MR with fat saturation.
Okay. So I think this lesion is centered in the left masticator space, but it's transspatial. It's extending superiorly into the medial or middle cranial fossa. It seems
masticator space. So we have muscles of mastication. You have the mandible. And what else important is in there?
The cranial nerve 5. So the what's it called? The Goose's pes anserinus.
No, that's the facial nerve.
Oh, yeah.
So the facial nerve is a pes anserinus or Goose's foot.
Oh, okay.
There's another pes anserinus in the knee, but that's not important. Only the one in the face is important. But when I do this, what nerve am I talking about that? That's 2 less than 7.
That's the one that's pointing down is V3.
5. So V3. And what does V3 go through?
Foramen ovale.
So this tumor is?
It's demonstrates perineural spread via V3.
So it's going up V3 and it gets up V3 into what?
Through the foramen ovale.
Through ovale. What's above that?
The middle cranial fossa, the trigeminal ganglion.
The semi-lunar ganglion or trigeminal ganglion. And that is inside the
Meckel cave.
Meckel's cave or the trigeminal cistern. So tumor can go from the masticator space up through ovale and get to the
trigeminal ganglion, the
trigeminal cistern or Meckel's cave.
Yeah.
Tumor from the masticator space can go up through ovale along V3 into the Meckel's cave or trigeminal cistern. From there, it may go forward into the
cavernous sinus.
Cavernous sinus, or go back towards the
towards the porous trigeminus and the
through the porous trigeminus, right, and the prepontine cistern to the pons. Right, good job. So, what kind of pathology would you think about? We have a mass centered in the masticator space that's going up ovale into Meckel's cave or the trigeminal cistern.
I'm thinking of schwannoma. Also,
what's a common tumor to have perineal tumor spread?
Adenoid cystic.
Adenoid cystic is a pathology really likes perineal tumor spread, but just statistically, most of perineal tumor spread we see is with what? What's the most common head and neck cancer?
Squamous cell.
Squamous cell. We see far much more perineal tumor spread just with squames than we do anything else. Adenoid cystic really likes it, but anything can have perineal tumor spread. We can see it with lymphoma. We can see a lot of different things with it. What is another common mass that we might think about in a differential for the masticator space a space that has all these big muscles?
Sarcoma.
Sarcomas love the masticator space, all flavors. Whatever words you want to put in front of a sarcoma, those things happen in the masticator space at that location.
Mhm.
Good. Okay,
Did
so I
this
got
turn
one
out-
more. What?
Do you, what did this turn out to be?
I think this was a squame.
Okay, so squames can occur frequently in the masticator space.
Can they? You tell me.
Yes, I didn't realize that.
Does pathology from another place often go to the masticator space?
Yes. Oh, okay. Odontogenic source.
Odontogenic stuff.
Okay.
Do you often get squamous cell carcinomas arising near the teeth?
Yes, in the
Yeah.
oral cavity.
That's totally a thing. So we think about that anatomy and where things are. That's very important for us, right?
Okay. Okay.
What is this shape right here that you see up there?
Um, the shape, that little kidney bean shape you
It's kind of like a kidney bean,
uh
almost a semi-lunar shape.
the semi-lunar ganglion.
That's the semi-lunar ganglion. Do you see it?
No.
Do you see a little thing that's shaped kind of like that right there?
Oh yeah, yeah.
What is that?
The semi-lunar ganglion
That's the semi-lunar ganglion of what nerve?
of cranial nerve 5.
And what is that inside of? The semi-lunar ganglion is inside of what?
No, inside of Meckel's cave.
Meckel's cave of the trigeminal cistern. Good. Good job. Okay, one more, then I gotta go. Who's next?
I am. Okay. Looking at two coronal CTs of the sinuses, bone windows. And we have extensive mucosal thickening of with opacification of the right frontal, right middle, and right maxillary sinuses. So this is a specific pattern of sinusitis, osteomeatal pattern or something like that, or infundibular, or
Osteo, like OSTEO?
something like that.
Osteo, OSTEO, that's like bone.
Oh no, like OSTIO or
Opening, OSTIO, osteomeatal.
Mhm.
So all the structures that make up the osteomeatal unit are important in the functional drainage of the paranasal sinuses.
Yes.
So if you
and
think
we'll be-
about where the triangle is of the maxillary sinus,
Mhm.
there's a drainage of the max. So the superior and the medial part of the maxillary sinus, the infundibulum where it drains, the uncinate process, the bone that makes the floor of the infundibulum. The ethmoidal bulla is the bump that is above the infundibulum, and then it drains into the hiatus semilunaris, and then the space under the middle turbinate. If you think about where the turbinates are, that's called the middle meatus. All of those structures make the osteo, O-S-T-I-O, osteomeatal unit or osteomeatal complex. So the superior and medial part of the maxillary sinus, the infundibulum, the uncinate process, the ethmoidal bulla, the hiatus semilunaris, and the middle meatus, the air-filled space that's under the middle turbinate, all of those make up the OMU or the OMC. That is important for functional drainage. And you're saying that this guy could have an obstructive lesion and he's likely to respond to FES, functional endoscopic sinus surgery. Hopefully your surgeons are doing FES, functional endoscopic sinus surgery, and not DES, dysfunctional endoscopic sinus surgery, where you end up. Good.
Yes, you put it very elegantly, but I had the exact same thought.
You did? That's great. Okay. So I will stop there. I got to get on another call. So I have more time tomorrow if you guys want to do more.
Of course.
Do you want to do more of this tomorrow, or have you had enough?
Yeah.
Definitely.
Thank you.
So same time tomorrow, I'll
Thank you.
have more time. I'm not doing clinical work and playing doctor.
All right.
Great.
And
Thank you,
let
Dr.
me know
Wiggins.
if you
Thank
want to do this
you.
format or something different.
I like this.
Yeah.
Yeah.
Good format.
Okay.
Thank
All
you.
right, thanks, guys. See
Thank you,
later.
Dr. Wiggins.
Bye.